lock us in. We have a very exciting episode today where we're going to be talking about hernia. I have two of my colleagues here today, Dr. Daniel Guerron, who's a general surgeon, and I have Dr. Miguel Bravo, who is a plastic surgeon. And I want to, first of all, take a little bit of time to introduce themselves. So, Dan, why don't you tell us about yourself a little bit?
Thank you, John. My name is Daniel Guerron. I'm one of the general surgeons here. I had the opportunity to train in Cleveland Clinic, Ohio. And then I did a specialty in advanced GI surgery and minimal invasive surgery at Duke University. I worked there for about 7 years, and I have the privilege to be the director of the hernia center here at Cleveland Clinic, Abu Dhabi.
Thank you, Dan. Miguel?
Hi, John. I trained in Spain, in Madrid, in my home city. I did my plastic surgery training there, and then I went to the U.S. for a fellowship in Beth Israel Deaconess Medical Center in Boston. And then I came back to Spain for 4 years doing private practice, mainly focusing in body contouring in Marbella, in the south part of Spain. And I'm very honored to be part of the Cleveland Clinic Abu Dhabi family since the last 2 years.
Thank you, Miguel. Thank you, Dan. And my name is John Rodriguez. I'm the Department Chair of General Surgery at Cleveland Clinic Abu Dhabi. So, Dan, I'm going to start with you. So what is a hernia?
Very good question. Hernia, in simple terms, it's a hole in the abdominal wall. It can go anywhere from the end of the thorax, the rib cage, up to the groin area. And you can have many, many different holes or defects in the anatomy of the abdominal wall. So in simple terms, it's a hole in your abdominal wall. You can have them at the diaphragm. It's called a hiatal hernia. At the belly button, an umbilical hernia. And at the groin, an inguinal hernia. And most importantly, you can have hernias after any surgery or any procedure that we do. You can develop this defect that allows the content of the abdomen to go through this defect to the outside.
So I have a very interesting question here, which is I wonder how a hernia surgeon and a plastic surgeon came together to talk about this topic. So tell us a little bit, Miguel, about how the two of you work together.
So when we look at a patient with a hernia, we are not looking at the hernia alone. We are looking at, as we just said, a patient with a hernia. And those patients can have other conditions combined with the hernia, like some excess skin or laxity of the skin or some fat deposits in the abdominal region that might want to have also repaired in the same procedure. And that's why we come together to provide the best care for these patients, combining both procedures, the hernia repair and some additional body contouring procedures that the patients might be willing to undergo during the same surgery.
So the idea is for patients to not only feel better, but also to look better after their operation.
Exactly.
Great. So talking about that, how does a hernia, Dan, affect the quality of life of those patients that are suffering from hernias?
The main issue with this is since you have a protrusion or the content of the abdominal cavity is coming out of this defect, you can have symptoms of a deformity, a clear deformity in your abdominal wall, something coming out of your body, or you can have some discomfort or pain with this content going in and out. Sometimes you can have emergencies like this content getting trapped in this defect. But I think one of the most important thing, and this is why we collaborate with plastics, is that it's not only the anatomical defect that needs to be repaired, is also the quality of life and the insecurities that some patients can have from this deformity and the consequences in the skin or the scars and the incisions. So I think if we team up, we can provide a better service for the quality of life of our patients.
Good. So I've been hearing and seeing a lot of patients here that come with this diagnosis of something called diastasis. So Miguel, what is diastasis and how is it different from a hernia?
So during pregnancies or when the patients have abdominal or central obesity, the muscles that we have in our core, like the six-pack, like Cristiano Ronaldo six-pack, tends to separate, and that's what it's called in medical term a diastasis, a separation and it's called diastasis recti because the recti are the muscles that are separated. That is different from a hernia in the sense that it's not a hole, as Dr. Guerron mentioned before, but it's that separation of the muscles. During the surgery of the hernia repair, we might need to do also a diastasis recti plication, or bringing the muscles together to tighten up the abdominal wall and provide like a flatter and more solid and strong abdominal wall.
So, can you have diastasis and a hernia at the same time, Dan?
Yes, and it actually is quite common to have a defect in the abdominal wall in the midline and the separation of the muscles. Sometimes risk factors, as Dr. Bravo said, central obesity or pregnancy will stretch those muscles, and a pre-existing hole like an umbilical hernia will get enlarged. So it's quite common to have these two entities coexist. And the most important thing is not only address the hole, but address the separation of the muscles. If you don't do that, you can potentially put some patients at a risk of the hernia coming back.
So, Miguel, you were talking about how the six-pack muscle can get stretched out, and I'm assuming that if you're going to fix that, you're going to have to make a very big incision all the way from the upper bone to the lower bone. Is this correct?
So that's a great question. Actually, we don't need to do that type of incision. We can do it just with the incision in the lower abdomen, that in most cases is more or less like a C-section scar, like after a cesarean section. And also in some cases where there's not too much excess skin to remove, we can actually do a minimally invasive approach that Dr. Guerron does for the reparation of that diastasis recti, and combine in some cases with some liposuction to give also a better shape from the outside.
So, Miguel mentioned minimally invasive surgery, Dan. What is minimally invasive surgery?
Minimal invasive surgery is a surgical technique in which we minimize the size of the incision, so we minimize the impact of the surgery by creating smaller incisions and using a means of expanding the area in which we want to work. In this particular case, we use some gas to produce a space, and then we put little fiber optic cameras to enter this space, and we use small instruments. We can call them some like chopsticks instruments that aid us in the dissection of these spaces. The impact in the body is that you decrease the size of the incisions, therefore avoiding complications like skin infection or bleeding in some cases, and also you reduce the impact in the physiology of the body, right? So instead of having these long incisions, you have 3 small keyholes that you can hide them in strategic places and perform the same operation that you're doing in an open fashion.
So, you both mentioned and talked a little bit about how you work as a team, and I think Dan mentioned the word that we are a program. We're not just, isolated surgeons doing things on their own. So, Miguel, can you share a little bit about your experience since you have been here and you have teamed up with Dan about how you guys came up with this hernia group or this hernia collaborative team to help our patients?
So patients will come generally through the general surgery department from the hernia program, and those patients that are willing to have some other body contouring additional procedures, they would come to our clinic in plastic surgery. And also the other way around, there are some patients coming to our clinic for abdominoplasty or for other body contouring procedures, and during the physical examination we might find a hernia, and then we refer the patient to our colleagues in the hernia program to evaluate the patient. So it's been very, very successful, I think, to this moment, and we've been able to treat many patients with these procedures and combined surgeries in a very smooth way with a very high patient satisfaction.
That sounds great. So,
If I may, I just want to add something to Dr. Bravo is we are just a part of a multidisciplinary approach that includes not only plastic surgeons, general surgeons that are experts in abdominal wall reconstruction, but also bariatric surgeons in those patients that need to drop some weight in order to qualify for a better hernia or a body contouring procedure. We have a nutrition team that will help us either improving the nutrition prior to surgery. We have obesity medicine for those patients that want to lose weight but they are not interested in surgery. We also have physical therapy. In summary, I think that we are only part of a big center that we're creating, and the innovation here is a multidisciplinary approach that not only takes care of the body and the disease, but we take care of the entire patient as a whole.
Yeah.
that's great. Thank you for sharing that, Dan. So I wanted to, in that same regards, I think one of the challenges that we face with many of our patients who are seeking care is the incidence of smoking in the Middle East. So Miguel, I wanted to ask you a little bit about that. How does smoking affect healing after body contouring, plastic surgery, and hernia surgery? And is it necessary for patients to quit smoking before the operation?
That's a great question, actually. And a lot of patients get surprised when a plastic surgeon asks them if they are smoking, because they only associate tobacco with lung disease, you know? And they might ask, like, why a plastic surgeon is asking me if I smoke or not. And it's actually really, really important for us because the tobacco affects the small vessels that are essential for wound healing. So patients who are heavy smokers that have a high smoking levels, those are in higher risk of having wound problems, wound dehiscence. In my experience to this date, I have to say that comparing with the population in Spain, there's much less smokers, at least the female patients there. I mean, it's very hard to find female smokers. They actually laugh when I ask them if they smoke. They're like, no, I don't smoke. But it's really, really important to make sure that the patient is not a heavy smoker for this procedure because there are higher chances of having wound healing problems.
I see. And you mentioned something called wound dehiscence. So what does that mean?
So a wound dehiscence means that when we suture a wound, we leave it closed after the surgery, of course, but then during the healing process, it might open. And that's what we call a wound dehiscence. And it can happen because of an infection in the wound or some sutures might come out. And that's a problem because that delays the wound healing and it will take a longer time for the wound to close. And in some cases, it will leave a not so aesthetic scar, let's say.
So it affects you a lot in the way that you anticipate the skin mainly in these surgeries to heal and the possibility of them getting infected.
Exactly.
And the where the closure is, and you do your beautiful job of it falling apart. But Dan, does it affect the risk of the hernia coming back as well?
Yes, indeed. Not only the healing, obviously, plastic surgery takes care of the contouring and the shape and the scar that it's visible. But when I am in this minimal invasive approach, I also need healing for this hole to close and get better. So if you have an impaired healing because of this microvascular impact from the smoke, you might have problems. But not only that, smokers typically cough. And when they cough, they have a significant increment in their intra-abdominal pressure, generating tension on that repair. So if you don't stop at a prudent time, typically 6 or more weeks before the surgery, and you have this cough reflex, you're going to put a stress on your repair and in your wound healing.
So you talked about the risk of hernias coming back, and one of the hot topics in the hernia world that I think we get a lot of these questions from our patients, and if you go to the news, we see a lot of this good and bad publicity about it, is this concept of a mesh. So Dan, can you tell us a little bit of what is a mesh and how does that affect hernia surgery?
It's a very good question, and perhaps Miguel and I will disagree a little bit on this topic, but we all understand why. A mesh is essentially a net. It's like, in simple terms, it's a mosquito net, right? It's made out of plastic for humans. There's different materials. The most common we use is polypropylene, different sizes, different meshes. The whole purpose of this mesh is to create a significant inflammatory reaction that promotes the scarring and reinforce the layer that we're trying to repair. So, in order to prevent a recurrence, if you have a mesh that generates this extra strength in the tissue that you repair, you are protecting the patients for the hernia coming back or a recurrence, which is the definition. I think in the hernia world, mesh is rather important to prevent a recurrence. It actually drops it in some series between 25 to 30% the chances of the hernia coming back. But when you combine procedures with body contouring and soft tissue, perhaps it gets a little more tricky. So we had algorithms and we've compromised, and I don't know the stance by Miguel, but definitely for the hernia world, mesh can be necessary.
What about the plastics world? I assume that it increases also the risk of wound complications and probably higher risk of infection because it's a foreign body.
Exactly. So for the hernia, it's what Dr. Guerron, I totally agree, and that's the beauty of working together. Like we also like combine approaches, but for other cases, like for the diastasis repair, for example, to place the mesh, and if we are combining with the body contouring procedures, that's at the end it's a foreign body until it integrates with
the muscle.
With
yes.
the muscle. But during that process, it can increase in some cases the rates of like fluid accumulation or like seroma that might happen. But the important thing with our approach is that we see every patient individually and decide what's best for each case.
So it sounds like you work great as a team and make these decisions together. So I want to change topics a little bit because one of the key elements of our DNA at Cleveland Clinic Abu Dhabi is innovation. And I want to talk a little bit about what makes this program special and ask you, Dan, what are the innovative techniques or technologies that you are using in your practice along with Miguel to offer the best results and the best strategies to our patients?
Yes, one of the missions of the Cleveland Clinic Abu Dhabi is to offer the most innovative and the best procedures. I think one of these is the procedure that we're offering here, diastasis recti, with a minimal invasive approach, 3 small incisions. And you can use techniques using a laparoscope and the 2 instruments that I referred earlier, the chopsticks. Or nowadays we have the good opportunity to use robotic platforms that not only allow us to have the same invasiveness, the same 3 keyholes, but also allows the instruments to move in a similar way as the hands of the wrist of the human hands, and they have increased 3 divisions. So there are platforms that will enhance the procedure itself, the technique, using the laparoscopic platform. This further enhances and benefits the patient because decreases the invasiveness of procedures that otherwise will only be possible doing in an open fashion. So I think that we have a robust robotic program here, and we have extremely talented laparoscopists, people that are experts in MIS surgery. So we're offering the latest operations for diastasis recti, either using the laparoscope or the robotic platforms in order to solve these problems. I think that is the best innovation. And the number two innovation, if I will, not only the technology and the techniques, but the multidisciplinary concept. I think it's a big thing here. Those are the reality in the Cleveland Clinic Abu Dhabi. We are also exploring artificial intelligence platforms, national registries, and things like that has not been able to happen in the UAE. But now Cleveland Clinic is pushing really hard to do this.
Miguel, what about from the plastic side? So are there any technologies or techniques that are unique to Cleveland Clinic Abu Dhabi that you have been able to pioneer here compared to some of the techniques that we were doing a few years ago?
So from our side, one of the main innovations is the using of that fat that we are removing and transferring to other areas of the body that might be a concern for the patient. So as we discussed earlier, we are looking at the patient as a whole. So we are not looking only at the abdomen. That's what I always tell my patients. I don't look only at the abdomen. We look at also the flanks, the proportions with the whole body, the chest, everything has to have a proportion. So in some cases, we can use that fat and transfer it to other areas like the hip dips or to the chest or the breast, to different regions. And we guide that with an ultrasound. It's a handheld ultrasound that's portable, and we connect it to the systems, to the iPads and everything that we have, and guide that infiltration of the fat directly where we want it with the ultrasound guidance.
Interesting. So I gather that you guys are both at the really the top and the apex of technology and patient safety. And I want to ask you a question because this is a very common question that I get from my patients, and I want to get both the American and the European perspective. So if myself or one of my family members has or is diagnosed with a complex hernia, do you think they're going to get the same care here at Cleveland Clinic Abu Dhabi that they would in the United States or in Europe? Or are there any technologies that we have not been able to adapt here in our hospital?
I think that we have the exact same technologies. We have the exact same setup. And most importantly, we have a very, very good human power here. We have practitioners, surgeons, caregivers that will deliver the same or better, maybe, care that you can get in the US. The most important thing here is that we develop teams, develop multidisciplinary approaches, and we see the patient as a whole.
What about you, Miguel?
I totally agree. I mean, I've never been in a hospital or an institution like this before. It's amazing how everyone works together, looking the best for the patient. And as Dr. Guerron mentioned, the human power that we have here, it's great, and everyone is like really looking forward to push the envelope to get the best outcomes for our patients. So I think absolutely, I mean, it can get even better, I would say, than in Europe. Yeah.
Great. Well, I would like to thank you both for taking the time and sharing your experience with us today. And I want to thank our listeners from The Doc is In, and thank you very much.
Thank you.
Thank you.